Hey, it's Adam Sewell, MD. Welcome to Module 7, Section 7.2 of the Microplastics Toxicity Training, certified by the Microplastics Health Alliance. In this session, we're moving into the second key phase of microplastics treatment, detoxification strategies with a specific focus on mobilization and binding. Now that the patient has reduced their exposure, the next step is helping the body release and eliminate what has already accumulated: plasticizers, nanoplastics, and the secondary toxins they disrupt. This is where we turn our attention to metabolic activation, hepatic conjugation, and GI binding protocols. Part 1. Why mobilization is a controlled strategy. Let's begin by making one thing clear. Mobilization is not the same as flushing. We're not trying to force toxins out of the body all at once. Instead, we're engaging the body's own systems, particularly the liver, lymphatic, and fat stores, to safely transfer sequestered toxins into routes of elimination. Think of it like this. If microplastics and plasticizer residues are stored in the tissues, then mobilization is the process of pulling those stored molecules back into circulation for processing and clearance. Part 2, metabolic support, glutathione, N-acetylcysteine, NAC, and alpha-lipoic acid, ALA. Let's start with the key molecules we use to activate detoxification enzymes and support conjugation pathways. 1. Glutathione, the master intracellular antioxidant and key molecule for phase 2 conjugation. Conjugates with BPA, phthalates, and styrene oxide via GST enzymes. Dose 500 to 1,000 milligrams per day liposomal or 600 to 1,200 milligrams IV weekly. Use in nearly all patients unless contraindicated. 2. N-acetylcysteine, NAC. Glutathione precursor that supports both detox and immune resilience. Dose 600 to 900 milligrams twice a day. Shown to reduce oxidative DNA damage and improve hepatic GSH levels in toxicant-exposed patients. 3. Alpha-lipoic acid, ALA, redox recycler that also supports mitochondrial detox and heavy metal mobilization. Dose 300 to 600 milligrams per day. Beneficial in patients with neurologic symptoms or insulin resistance. Clinical references: Rushworth et al., 2014, Biochem Pharmacol, N-acetylcysteine suppresses tumor necrosis factor alpha, protects hepatocytes. Genuis et al., 2012, Scientific World Journal, reported that induced perspiration may help eliminate BPA and certain phthalates, and mechanistic literature supports glutathione-linked detox pathways. Pizzorno et al., 2014, Integor Med, summarized role of ALA in environmental detoxification. Part 3, binding strategies, types, rotations, and mechanisms. Now let's talk about binders. These are agents that capture mobilized toxins in the GI tract and escort them out through the stool. Without binding, you risk intrahepatic recirculation, where conjugated plasticizers excreted into the bile are reabsorbed and recirculate indefinitely. Key binder types: 1. Activated charcoal, broad-spectrum binder for organic toxins and plastic residues. Dose 500 to 1,000 milligrams at bedtime, away from medications and food. Caution: may cause constipation if not taken with water. 2. Modified citrus pectin, MCP. Binds low molecular weight compounds like BPA and lead. Supports microbiome health compared to other binders. Dose 5 grams per day, divided twice daily. 3. Chlorella, algae-based binder that also delivers minerals and supports GI immunity. Dose 1 to 3 grams per day, best in split doses. Particularly helpful in patients with metal co-burden. 4. Cholestyramine, RX only. Bile acid sequestrant, very effective at binding lipophilic plastic metabolites. Dose 4 grams twice to 3 times a day. Monitor for vitamin A, D, E, K depletion and drug interference. Rotation protocol. Example: weekdays AM MCP, PM charcoal or chlorella, weekends binder holiday for microbiome recovery. Use probiotics and butyrate support. Clinical references: Genuis et al., and subsequent interventional studies report that cholestyramine, a bile acid sequestrant anion exchange resin, enhances gastrointestinal elimination of PFAS. A National Academies review notes small human studies where cholestyramine increased fecal excretion of PFAS, and a 2024 randomized trial with an anion exchange resin, cholestyramine, reported approximately 60% PFOS reduction over 12 weeks, consistent with blocking enterohepatic reabsorption. Part 4, Clinical Case Snapshot. Let me share a quick patient example. A 42-year-old man with fatigue, low testosterone, and brain fog begins a detox protocol with glutathione 500 milligrams per day, NAC 900 milligrams twice a day, and charcoal at bedtime. Within 10 days, his fatigue worsens and he develops mild bloating and irritability. We realize the problem isn't mobilization, it's lack of clearance. His bile flow and GI elimination hadn't been optimized. We add magnesium citrate 300 milligrams per day, increase hydration, and introduce MCP. Within 5 days, his symptoms subside and begin to improve. This reinforces a key principle. You must never mobilize more than the body can eliminate. If elimination stalls, toxins recirculate, and patients feel worse, not better. Part 5, monitoring and adjustment. Labs to monitor GGT, glutathione demand, ALT/AST, hepatic strain from mobilization, HSCRP, inflammation during detox, urinary BPA/MEP/MBZP, recheck at week 6 and week 12. Signs to watch for: increased fatigue equals overmobilization. Headache, irritability equals neuroinflammation or binder mismatch. Constipation equals binder-induced detox backlog. To wrap up, detoxification is not a race, it's a sequence. First, you reduce exposure. Then you mobilize stored toxins using glutathione, NAC, and ALA. But you must bind those toxins in the gut to prevent them from recycling into the bloodstream. Rotate your binders, support bile flow, monitor labs and symptoms, and always pace the detox to match the patient's current resilience, not their ambition. In the next section, we'll talk about sweat and renal elimination, how to use sauna therapy and strategic hydration to accelerate Phase 3 clearance. I'll see you in Section 7.3.